Hello, dear respected students. Today we are talking about syndrome of myocardial injury, also heart failure syndrome, because heart failure syndrome closely connected with damaging of myocardium. There are two types of myocardial injury: diffuse and local. Diffuse when damage whole myocardium, whereas in local damage only one part of myocardium. Local myocardial damaging mostly connected with the coronary insufficiency syndrome. That's why we close a study in future together with coronary insufficiency syndrome, for example, myocardial infarction. Today we will focus on diffuse myocardial injury. There are some causes of myocardial injury. On the first place of myocardial injury is myocarditis, inflammatory myocardial damaging. On the second place is cardiomyopathy, non-inflammatory myocardial damaging. Myocardium may damage because of ischemic heart diseases, may damage because of cardiosclerosis. Cardiosclerosis develop after myocarditis, may develop after atherosclerotic changes of coronary arteries, or may develop after myocardial infarction. Diseases that cause the development of myocardial hypertrophy due to an increase in load, for example, volume or pressure load in valvular heart disorders, also may result in myocardial damaging. Next is myocardial dystrophy. Trophic changes in myocardium may develop because of anemias, vitamin deficiencies, or endocrine diseases like hypo or hyperthyroidisms, or may develop because of dysmetabolic or dyselectrolytic disorders, even due to excessive physical activity or damaging of myocardium because of vibration or radiations. All these causes may result in disturbances of functions of myocardium: excitability, conductivity, and contractibility. Excitability damaging appear by arrhythmias, for example, paroxysm, tachycardia, or premature beating. Conductivity damaging may result in appearing by heart blocks like sinoatrial block or AV blockers or bundle branch blockages, and conductibility disturbances may result in a heart failure syndrome. Let's discuss from heart failure syndrome. Heart failure is syndrome in which heart under normal operating condition, not doing its functional load, do not provide adequate blood supply to organs and tissues. There are three types of heart failure: left ventricular, right ventricular, and biventricular heart failures. Biventricular, this is simultaneous damaging of both ventricles. For example, may develop because of myocarditis or heart dystrophies or cardiosclerosis or cardiomyopathies and congenital heart defects. There are two types of heart failure: diastolic and systolic dysfunction. A heart failure with systolic dysfunction is a reduction in force and velocity of myocardial contraction. It may develop because of myocarditis or dilated cardiomyopathy. Diastolic dysfunction is a disturbance of myocardial relaxation due to the excessive rigidity of the myocardium. May develop because of restrictive cardiomyopathies or because of hypertrophic cardiomyopathies. Heart failure syndrome may appear by two mechanisms, two syndromes: syndrome of retrograde congestion and small cardiac output. Because of decrease contractibility of myocardium, for example, left ventricle couldn't pump entire blood to the systemic circulation because it's very weak muscle. Weak muscle of left ventricle cause decrease in cardiac output. Also, weak muscle of left ventricle cause increase antiastolic pressure in left ventricle, also in left atrium, and cause enlarging of pulmonary veins and congestion of pulmonary veins, which cause the congestion of blood in lungs. Right ventricular weakness, right ventricular failure may also develop an increasing and diastolic pressure in right ventricle and right atrium, and also enlarging of veins, vena cava superior and inferior system. That's why we have congestion, retrograde congestion in vena cava superior and inferior regions. Let's start from discussing small cardiac output syndrome. This clinical manifestations depends on the degree of myocardial injury and the speed of development. Small cardiac output syndrome appear by two symptoms: tachycardia and shortness of breath. Tachycardia, the earliest clinical sign of heart failure. Reduced stroke volume of the heart is compensated by an increase in heart rate. Shortness of breath is characterized by deep breathing without the respiratory pause. Shortness of breath and tachycardia at rest, a sign of severe heart failure. In the early stages, it's necessary to identify the relationship of these symptoms with the level of physical activity. As the disease progresses, this level decreases. For example, at the beginning time, it may be shortness of breath and tachycardia, which appear only during excess physical activity, whereas in severe heart failure, this shortness of breath and tachycardia appear even at rest. During observation, you can find out pale skin and mucous membranes due to reduced blood supply of tissue. Also, you can find out symptoms of hypoxia like fatigue, dizziness, headache, fainting, pain in the muscle with a little exertion. There may be pain in precordium, coronary insufficiency syndrome. The decrease of muscle mass and subcutaneous fat, this is last symptoms which represent as cardiac cachexia syndrome because of degeneration of tissues and internal organs. Next is syndrome of retrograde congestion. Let's start from left side. Left ventricular heart failure resulting congestion in pulmonary circulation, which may appear by cardiac asthma, this periodic attack of breathlessness during the night during exercise, often mistakenly recognized as bronchial asthma. A position of patient is orthopnea position, you see on picture. You see, firstly, we have congestion of extra fluid in interstitial tissue at the end stage with the progression of ventricular failure. Alveolar acute pulmonary edema appear. The protein containing fluid from the interstitial tissue exudate in the alveoli, sometimes together with red blood cells. The incoming air in alveoli as a mixer form this liquid. There is a red blood cell containing form which goes from the alveoli through the bronchi, bronchial trees, fills and comes out through mouth. This we call as pulmonary edema. Sometimes may develop a wheezing sound, a sign of congestive swelling of bronchial tubes, like bronchial obstructive syndrome, a common cause of misdiagnosis and incorrect treatment of bronchitis. Right heart failure or retrograde congestion syndrome because of right heart failure appear by expansion of neck veins, increasing volume and pressure of blood in the right atrium and the superior vena cava, and lying position appear by jugular veins swelling and dilation of jugular veins. Dilation of right ventricle leads to relative insufficiency of the tricuspid valve. The reduction of right ventricle, the blood is pushed into the right atrium, and this wave is transmitted to the vena cava, a positive venous pulse we call. Next, neck vein pulsation also may pulsate the lower edge of enlarged liver at the end stage of right ventricular heart failure. Acrocyanosis on the peripheral organs, legs, lips, tip of the nose, ear lobes is a stagnation of deoxygenated blood saturated with carbon dioxide. Due to the slow blood flow has time to cool down, that patient's limbs are always cold. Peripheral edema may occur, starts to appear on the feet and legs, typically an increase in swelling in the evening and in decrease after sleep in horizontal position. The fluid is displaced by the force of gravity. Right heart failure also appear by massive swelling of uh, blood vessels, and massive swelling leads to compression of blood vessels and nerves of the lower limbs in subcutaneous tissue, which result in trophic changes of skin. Hepatomegaly, this is enlarged liver due to the swelling. Patients are often disturbed pressing pain in the right upper quadrant. On palpation of the lower edge of the liver protrudes from under the rib arch. Liver compacted in most cases is painless. In severe right heart failure, may accumulated fluid in abdominal cavity, as ascites in pleura, which cause the hydrothorax, and even in pericardial cavity, hydropericardium. Anasarca is a total swelling of subcutaneous fat, and congestion of bronchial veins can cause edema of the bronchi and appear of symptom of bronchial obstruction. During palpation, because of enlarging of heart, apical beat shifted to the left and down, apical impulse become to be wide. Pulse, during palpation of pulse, you can find out variety arrhythmias, for example, pulses irregulars, beat, atrial fibrillation, and other frequencies, for example, pulsus frequens, pulsus rarus. During percussion, you can find out size of heart, enlarged size of heart, enlarging of relative cardiac dullness, increasing in diameter. During auscultation at the top, at the apex, on the apex, there is a weakening of the first sound S1, and sometimes may appear systolic murmur in the apex. This noise, this murmur develop as a result of damaging to the papillary muscles, but it may also due to the expansion of left ventricle, the relative insufficiency or relative insufficiency of the mitral valve develops. Sometimes due to severe heart failure and arrhythmias, may develop pendulum rhythm. First and second sound S1, S2 are the same due to the shortening of diastole, and due to weakening of heart muscle because of myocardial damaging, may develop galoops. Protodiastolic, we distinguish two types: protodiastolic and presystolic galoop. Protodiastolic galoop due to the formation of S3 audibility as S3 sound. If you auscultate lab dub and again dub, three sounds, lab dub dub, lab dub dub, this will be protodiastolic galoop. If you are auscultating first S1, S2, and S4 sound, this we call as presystolic galoop. In lab diagnosis, there is an increase in the concentration of cardio-specific enzymes and myocardial proteins in myocardial damaging syndrome. Of course, will increase creatine phosphokinase, mostly increase cardiac isoenzyme creatine phosphokinase MB fraction. Creatine phosphokinase, we know there are three types: MB fraction, which may increase because of damaging of myocardium. Also, we recognizing BB function when damage the brain, and MM function when damaging the skeletal muscles. In these cases, we have increasing of MB fraction of phosphokinase. Also may increase lactate dehydrogenase and troponin I and troponin T, and also myoglobin. In patients, there is a change in protein composition of blood, alpha, beta, and gamma globulins, the concentration of sialic acid and C-reactive protein, and also fibrinogen increase. If myocarditis, for example, myocardial damaging syndrome because of myocarditis, of course, inflammatory patterns will be increased. It's important in diagnosis process to use immunological tests and indicate myocardial damaging by immunological tests, because immune changes persist for a fairly long time, up to 1.5 years or more. In 40% of patients with myocarditis, for example, cardiac antigens, which are autoantigens, are detected in the blood serum, and in 70% of patients with myocarditis, anti-cardial antibodies to various proteins of the cardiomyocyte cytoskeleton are detected, which are in circulation for up to 1.5 years, and also may increase the pro and anti-inflammatory cytokines like tumor necrotic factor or interleukins 8 or interleukins 1 or 6. Severity of increasing depends on stages of inflammatory process or non-inflammatory processes. Also, by lab test you can find out heart failure markers like atrial natriuretic peptide, brain natriuretic peptide, and natriuretic peptides are members of the family of hormones secreted by the atrium, ventricles, and vascular endothelial cells. The main stimulus for their secretion is increase in myocardial tension with an increase in pressure in the left ventricle of the heart. In heart failure, plasma ANP and BNP concentrations increase in proportion to the threat of cardiac arrest. Also, you can use the detecting of innovative biomarkers like copeptin. Together with troponin, copeptin allows timely exclusion of myocardial infarction. Also, you can provide the endomyocardial biopsy. Especially, we use myocardial biopsy because used to differentiate myocardial damaging syndrome. For example, viral myocarditis or myocarditis, any types of myocarditis, from cardiomyopathies, non-inflammatory disorders you see here. For example, viral myocarditis and the myocardial biopsy, and also biopsy in restrictive cardiomyopathies. Also, you could use instrumental methods like ECG and echocardiography and X-ray. ECG observed different rhythm and conduction disturbances, sign of failure of coronary circulation, or low voltage ECG, or flattening of T wave. X-ray marked expansion of shadow of heart in diameter, and echocardiography study to determine violation of general and local myocardial contractibility, hypokinesia, akinesia, or dyskinesia, or thinning of walls, or hypertrophy of walls, dilation of heart cavities, and associated with valve insufficiencies. For example, on this picture you see myocardial damaging syndrome. There are two different patients. In one patient, myocardial damaging syndrome may appear by premature beating, ventricular premature beating. This is disturbances of excitability of heart. And for another patient, for example, patient with cardiosclerosis may give us low voltage ECG. What does it mean, low voltage ECG? When in standard leads you see decreasing of R wave less than 5 millimeters, and in chest limbs, precordial limbs leads you see decreasing of R waves less than 7 millimeters, and also you see flattening of T wave. This is sign of cardiosclerosis, and this sign of a very weak heart. And echocardiography may show you different enlarging of the heart chambers, and also insufficiency of and regurgitation of blood here if develop relative insufficiency or valvular insufficiencies, and also may give you information about the about the wall of myocardium, and a Doppler echocardiography shows your, of course, pressure in chambers. X-ray, this helper method detect only secondary changes. In the beginning, X-ray give you enlarging of heart size to the left and right side, and you see transverse size of heart is enlarged, and normally heart border should be inside the midclavicular line, and you see here is this our heart expand to the right and left side. And also here you could find out the congestion of heart, central venous and peripheral pulmonary congestion. This is complications of heart failure is a retrograde congestion. Retrograde congestion, and also this retrograde congestion you see on right and left side, and also on this picture. Also, of course, you could use CT scan, MRI, if it's possible. Okay, thank you for your attention. I finished my lecture.